Okay, hi guys. Welcome to my first pharmacology lecture. I'm Chad Peterson, and I'm a practicing pharmacist. I work at Abbott Northwestern Hospital. I went to the University of Minnesota and I'm a formal Bethel grad. I'll do a more thorough introduction on my background when we start class in the fall. I am the instructor for the pharmacology course sequence, so you'll be seeing a lot of me starting in the end of August. This lecture today is an introduction that's going to focus on two really core concepts that relate back to all parts of pharmacology, and that's pharmacodynamics and pharmacokinetics. So first question we have is a very simple one, but also somewhat complex. So what are drugs exactly? Well, the definition of a drug is on the slide here, and it's defined as a substance, or which would be a chemical agent that affects a biological system in a potentially useful way. And we use drugs for the prevention, diagnosis, treatment, and cure of disease in humans or other animals. Now, the other definitions of poison and toxin can relate to drugs too, and I do a toxicology lecture in the third semester, so we'll talk more about that at that time. But a poison is defined by a chemical agent that produces a harmful effect. Note, drugs in high concentrations can become poison, so really it depends on the dose. If you give too much of anything, it can become a poison. And a toxin is a poison of specific biological origin, but toxins can also be used as pharmacologically beneficial agents as well. There are many examples of toxins found in nature that have been modified or slightly changed or used at lower doses to achieve therapeutic effect. The first step here is pharmacodynamics, so what drugs do to the body, versus pharmacokinetics, which is more about talking about what the body does to drugs. So receptor basics is really important. You've probably had some exposure to this throughout your pre-PA school training, but just to review what we're talking about when we're talking about receptors, and this is going to be really important as I'm going to talk a lot about drugs and their as being agonists or antagonists on certain receptors, and it's going to elicit different types of responses. So essentially what an agonist is something that elicits a pharmacologic response. So an agonist binds to some sort of a site, a receptor, and causes something to happen. There's also partial agonists, which get a little bit confusing, and these produce somewhat of a response, but not fully. And partial agonists may also be used in a beneficial situation because they compete with other agonists. So for example, there's a drug out there called buprenorphine, which is a opioid partial agonist, and it's used a lot for people who are chronically addicted or have a history of substance abuse of opioids, like people maybe who have been on chronic pain medications for a long time, or maybe heroin addicts may use these medications to help provide some sort of opiate-like stimulation, as it's a partial agonist, but also it would have the same effect like if they were, for example, a recovering heroin addict taking buprenorphine and they injected a large amount of heroin. That partial agonist would also compete directly with the heroin for the action on that specific receptor. And in that case, it also acts almost like an antagonist to certain degrees. So you get these partial agonists that kind of walk a fine line between the two, but technically it's more on the agonist side than the antagonist side. So getting to antagonists, what are these? Well, they are non-pharmacologic response. So basically all that an antagonist does is it binds to receptor without activating it. Now you have multiple types of antagonists. So think of antagonists also as blockers. So when we talk about a really common class of drug called beta blockers that work to slow down the heart rate, they're used for blood pressure management, they're used for a lot of different cardiac conditions. Those are beta receptor antagonists, but blocking is kind of the more layman's term for it. So talk about medications that block different receptors. We're talking about antagonists. So what it's doing is preventing some sort of endogenous function from actually taking place. So you have endogenous mediators, and in the case of beta blockers, your beta receptors are activated by the sympathetic nervous system. So by blocking that response, prevent the sympathetic nervous system from activating those receptors. Therefore, you have an antagonist. You have competitive versus non-competitive. Some antagonists will compete for a binding site with the endogenous transmitter. Others are non-competitive. They may bind to a separate site that has an antagonist effect and prevents binding. And I'm going to show some more examples of these in a minute in case you're getting confused already. And then you have reversible versus irreversible. Some antagonists will bind on, and then they will lose their they will basically dissociate from the receptor for a certain amount of time. And there's irreversible binding that may bind, cause an irreversible effect, and you'll just have to wait for it to go out. So maybe it's binding to I don't know, like a platelet, a receptor on a platelet, and that platelet life cycle has to end before that effect is done. There's also things called functional antagonists, which are not necessarily full antagonists, but they work like an antagonist. So they create some sort of response in the body that's causing an antagonist-like response, but it's not really actually directly antagonizing a receptor. So it's a little confusing there. I like the terms dirty versus silver bullet to talk about drugs too. So some drugs are dirty, meaning they hit lots of different receptors or act on a lot of different physiological systems. And there's other ones that would be maybe more like a silver bullet, where they really just do one thing. They're very selective. They've been designed specifically to be selective to one specific area of the body and one specific receptor type. There are very few drugs that really only act on one physiologic system. Most of them will have effects other places, but we do have some that are much more silver bullet and some that fall much more into the dirty category. Okay, just to talk about some more terminology here, things you might see or read about when you're reading about drugs. Affinity is a drug's tendency to bind to a specific receptor. So you may hear me say like, oh, it has high affinity or low affinity. Whereas potency relates to the different types of bonding. So on a chemical level, we have van der Waals, hydrogen bonding, covalent, etc. Dust off your Gen Chem from your freshman year of college or whenever you took it, and trying to remember that stuff. But basically, that's where potency comes down to on a chemical basis. We want to look at it on a nitty-gritty detail level. But potency represents which agonists may have more affinity for a receptor. So remember, affinity is our tendency for the drug to bind to a receptor. And let's say one agonist is more potent, so maybe it forms a stronger type of bond with the receptor. Well, that's going to have more selectivity, and it's going to maybe that receptor is going to be more likely to bind with that higher potency agent than maybe the endogenous mediator that's not quite as high of potency. You have high doses versus low doses too, so we can overcome potency issues by upping the dose. So you see some drugs in the same class as other drugs that have really high doses, and then the same drug or a drug in the same class has a really low dose, and you're like, well, they work the same way, but why is this one dosed in 100 milligrams and this one is dosed in 10 milligrams? Well, it's usually because potency. One has more affinity for a specific receptor type, but we can get the same effect with the other one if we just give more of the drug. Drug efficacy, defined by the drug's ability to produce a biologic effect. And this may or may not be related to the potency of a particular substance. So some drugs, depending on where they work in the system, may just have a really good effect, and they may not be all that potent, but they actually are having a really strong biological effect. So a lot of this doesn't necessarily mean anything, as you're maybe finding out by the way I'm explaining it, or maybe getting confused by the way I'm explaining it. But you can have a really potent drug, doesn't necessarily mean it's going to produce a really strong biological effect, and vice versa. But usually those two things go hand in hand. So if you have something that's strongly potent, it should produce a decent biological effect in theory. Then we have specificity versus selectivity. Selectivity and specificity are defined as, specificity, highly specific drugs are going to bind to one type of receptor. So when we're talking about specificity, we're talking about binding to specific receptors, whereas selectivity is going to be drugs that are acting in only one place of the body. So a highly selective drug, maybe, and think about it, a drug that only acts in the specific receptors within the bladder area. For example, we have some drugs that work on incontinence that are bladder selective for specific receptors. And in that case, they're also not only selective to that area of the body, but they're also specific to one type of receptor. So you can gain selectivity by designing a drug to be specific, if that makes sense. So if you only have one type of receptor in one area of the body, you design a drug to target that specific receptor, that drug's also by definition going to be selective as well. So just to kind of keep that into perspective. And you can also have the other side of things. So you may have a drug that's very specific for certain types of receptors, but it may hit maybe all the receptors in the body. It may cross the blood-brain barrier, get into the central nervous system, causing side effects. Usually that's where you're going to see it, where a drug is specific for a certain type of receptor, but it's not selective. So it's going to be all over the body, and that's where we usually experience most of our side effects that are not intended, that are coming from the drug. Okay, talking about agonists a little more, just a diagram to point them out. You have your percent activity here and your concentration. So usually the higher the concentration, let's say it's blood serum concentration, if serum concentration and over time as you get a higher concentration, you're going to reach closer to 100% activity. And then you have your partial agonist, which is really just going to cap out at a certain point. It's not going to reach that full effect because it's not agonizing that receptor like the full agonist would. And you can see that chart I have at the top there. It's kind of a spectrum. It's just talking about your relative efficacy versus your endogenous. So if you have an endogenous agonist, and then what are we doing pharmacologically to mimic that? So we could have a full agonist that maybe has a very similar potency. You can have antagonists that are reversing that effect, or you could have what they call them super agonists, which we never really use that term, but it illustrates the point that you can have a drug that maybe gets more of a response because it's, again, we talked about possibly being more potent, having a stronger bond, and it may have more of an effect that way potentially. So there's multiple ways you can look at this. All right, and then we have our antagonists having a similar type of drawing here, just a logarithmic curve on this system. So we have agonist dose, and you have a log scale in there, and the percent of maximum effect here. So we have a couple different things to think about. So these are called dose response curves, and this figure shows presence of competitive and irreversible antagonists. A shows a competitive antagonist that has an effect illustrated by the shift of the agonist curve to the right. So you can see that the first curve, if you're looking at the slide on the left there, shows agonist alone and is illustrated by this curve here. I'll try and point it out with my mouse. And then you add an antagonist on board. So let's say this is your endogenous agonist. So this is maybe the sympathetic nervous system responding. Let's use the example of the beta blocker because it's pretty simple. So your sympathetic nervous system is going into effect. You're getting some agonist effect on the beta receptors of the heart. Well, let's say you give a beta blocker. Okay, well, that's going to shift this curve this way, meaning that you're going to have to up the dose of this agonist substantially to be able to get that same effect. And what that does is it makes it less effective for this endogenous agonist in this situation. So maybe your body doesn't have the capability to build a serum concentration high enough, or maybe it'll take it a while to do that, or even if it does do that, it still won't be quite as effective. That's kind of the theory behind an agonist. B shows a non-competitive agonist shifting the agonist curve downward, and this is just a little bit different. You can see we have a irreversible antagonist here that's just going to decrease the overall effect and ability of it. So this is already bound to the site permanently, whereas the competitive antagonists, they can have some, they're competing directly with the agonist alone. So remember I talked about competitive versus non-competitive types of antagonists. And competitive is obviously competing for the exact same binding site as the endogenous mediator, whereas something that's irreversible or non-competitive is not going to be competing for that same site potentially. Okay, I want to talk a little bit about some signaling opportunities that we have with drugs for the body. So here's a nice diagram showing some transmembrane signaling, which is a pretty common way that drugs and endogenous mediators communicate with cells. So we have here dopamine as an example. Dopamine's a neurotransmitter. Dopamine's used as a catecholamine. It's got a lot of functions in the body. So we have dopamine receptors all over the body. And here we have dopamine interacting with this specific D2, D3, or D4 receptor. So dopamine's that little wedge shape there coming in and locking in nicely, fitting into this perfect puzzle. And then here in this other drawing, we have an antagonist here. So the antagonist, of course, the difference being it doesn't have that little wedge at the bottom. So this is overly simplified, but the concept is there. So we have dopamine, which is a little bit different, which is designed specifically for the receptor. We have antagonists, which are designed to work with that receptor, but not elicit the full pharmacologic response, or to prevent that pharmacologic response from happening, actually. So we have the antagonist coming in. It fits in the spot, but it's not like dopamine, so you aren't getting this downstream regulation. So what happens with a lot of transmembrane signaling is this illustrates it well. So let's say that this wasn't the antagonist, this is dopamine. Dopamine is going to trigger these G protein coupled receptors to cause this kind of downstream flow of signaling, and you're going to get adenylyl cyclase, protein kinase C taking action. And ultimately, your goal is probably going to be to open some sort of channel. So in this case, you're looking at maybe opening a sodium channel and causing different types of cell signaling to happen that may not otherwise be caused. So dopamine would cause that to happen normally. Now, if you put an antagonist in here, see this big X goes through here. That means all this has been taken out of play. You aren't getting any of these signaling. Your sodium channels are staying closed. You aren't getting that effect like the dopamine would normally have. And that's the basics behind what transmembrane signaling is. And it also illustrates how an antagonist works as well. Ligand-gated ion channels have kind of a similar process. They're just a little bit more direct. So a ligand-gated ion channel usually has receptors on the channel itself, as opposed to the other one where we have the G protein that the receptors are on, and then that works in a downstream way to actually open the channel in a bit of a roundabout mechanism. These work directly on the channel. So we have, again, a sodium channel here. And 5-HT3 is an abbreviation for serotonin. Serotonin is another neurotransmitter. It's also ubiquitous in the body. There's tons of serotonin receptors, and we use serotonin manipulation for multiple different pharmacologic agents. So here we see serotonin binding directly to this ligand-gated ion channel and opening it up. So serotonin being our 5-HT here being our endogenous mediator. And then we have our antagonist coming in here saying, you know what, we're going to do something different, and we're going to block this so that the sodium channel stays closed. So it's a very similar concept. It's just when you have ligand-gated ion channels, you're working directly on that receptor or on that channel, receptors on the channel itself. Some other methods that we can work with as far as inhibiting different processes in the body or changing processes in the body is with enzymes. So there's lots of enzymes that affect various biochemical processes. And so here you have a bacterial enzyme, a couple of substrates that are interacting with it, and ultimately you're getting some sort of end product. So this could be something like a reaction maybe taking place in the GI tract or something like that. Now in this case, the illustration here is that you have the same enzyme, and you could replace bacterial enzyme with whatever it might be. So it could be any type of enzyme that you're working on in the body. You have the normal substrate, and you design a drug that's going to link up with the substrate in a similar fashion, but again, we aren't quite doing the same thing. What ends up happening is that comes together and it inhibits the enzyme from creating an end byproduct. So there's ways to work with not only the signaling pathways of cells, but also looking at the body's enzymatic functions and inhibiting those processes before they can get to a cell to create some sort of reaction. So just another way to look at how we can manipulate the body with drugs. Okay, so I talked a little bit about competitive and non-competitive antagonism already, but this is a diagram to illustrate it a little bit more. So when we have our binding sites here. So you can see this orangish square is the natural ligand. So this is our natural endogenous hormone or neurotransmitter, whatever it is. It's binding to the square site. What happens is that produces some sort of an effect. And then what we do is we add a drug, which is our competitive antagonist. And so this drug also binds to the same site. However, it competes with this one. So you may still have some of these sites in the body that are getting the endogenous drug, but you're getting several that are going to have the drug that we administered, or the endogenous hormone or neurotransmitter, whatever it is, competing. So again, we're competing for the exact same binding site here. And then once you compete, assuming you get the right concentrations, you should be able to compete so that you're decreasing the response completely if you get enough of the right dose, right concentration. Now, this drawing is simplified to show you that there's another binding site. There's this triangle shape here. And so we have different binding sites available on some of these receptors, or these G protein coupled receptors or ligand-gated ion channels. And in this case, you have a drug that's designed to come in and work on a different site of the receptor and not compete directly with the endogenous mediator. So they're both binding to the same area. So then you may still get some sort of response. In this case, they're showing you a curve that's saying you're dropping your response, but not all the way down. So they're saying it's not quite as effective as competitive antagonists. But in truth, you could have something that completely shuts down the function of this, even though you're getting still natural binding on the binding side. It may not have a partial signal. It may have it may inhibit the signal altogether, just another way of doing it. So there's multiple ways this can happen in the body. What was it? MTC and MEC. And here I'm using the ED50, TD50, and LD50. So ED50 would be the effective dose of 50% of the population. So that's the dose that ideally, if half the population took it, they would get a response. So we want something above that to really get adequate therapeutic benefit in most people who take it, right? We don't want less than that because that's less than 50%. TD50 is our toxic dose 50. So then we have in between there, again, it's kind of like looking at that area under the curve that we wanted at in our duration of action on the previous slide. We're looking at in between there being this margin of safety or margin of efficacy. And then the LD50, I put this line up here going way out there. So the LD50 is something you'll maybe read about if you read toxicology journals or read about drugs and their toxic effects. Lethal dose 50. So 50% of the people who take that dose would die. And a lot of times we don't have this information on drugs, but suffice to say it would likely be far outside of the realm of what we're looking at here within our therapeutic window. Okay, so I just want to talk about therapeutic index too. I'll mention various times throughout the course, some drugs have really narrow therapeutic window, so your therapeutic index. So if you shrink this, if you have a really small amount of space between your TD50 and your ED50, that's going to be a really narrow therapeutic index. Sometimes with drugs like that, we have to do regular monitoring, serum concentrations, to make sure we're reaching the right levels with the patient and not exceeding them or being or getting too low on our levels and not being effective enough. And the way that's calculated is by dividing the toxic dose 50 over the ED50. But really, the way to think about it is just that some drugs have a therapeutic index that's really narrow. Other ones have a really wide therapeutic index where, most patients get a really good effect even with a small dose, and you have to take a ton of the drug to really get a toxic effect from it. So really anywhere in the middle is fine. Most patients are going to tolerate it just without any issues. So I'll use those terms throughout the course describing possible toxicity for medication. So in a rule of thumb, anything with a really narrow therapeutic index, likelihood of toxicity is high. Monitoring is more key too. We're usually monitoring these people on a somewhat regular basis to make sure they aren't getting toxic or again are getting full therapeutic benefit too. So to review this, let's just talk about drug concentration and response from a general perspective. So if you have a drug that you're giving somebody, you increase the dose, that's going to increase your serum concentration. Increasing the serum concentration generally increases pharmacologic response, but you also get a risk of increased side effects. So really, again, the concept here is that we're walking this line in between pharmacologic response and getting side effects. And we don't want side effects, and we want pharmacologic response. So the question is, how can we meet in the middle? Sometimes we can't. Sometimes we're going to have some side effects in order to have an effective drug. But the question is also, are those side effects acceptable to the patient? Are they, are they going to cause quality of life issues? Are they something we can work around? Are there ways we can avoid them? There's like maybe a drug causes excess sedation during its Cmax period. Well, maybe you have a patient take that at night before they fall asleep. So there's ways you can work around these, but oftentimes in a perfect world, yes, we would have a drug that we get to that perfect pharmacologic response without hitting any side effects, but a lot of the times it's just not possible. So question is getting the pharmacologic response, minimizing side effects overall. And a lot of drugs we have are pretty good where we don't necessarily have to worry too much about side effects, but that's always a risk we're thinking about. I had a professor in pharmacy school who said his way to sum up this whole thing was simply double the dose, double the concentration. If you remember that, you'll be all set. And this is a concept that makes sense for linear drugs that work and are absorbed and excreted in a linear fashion. So yes, if you double the dose of the medication, you're going to double the concentration in the bloodstream. So If you have a patient who's not getting a response, double the dose, and hopefully you're doubling the concentration, increasing your pharmacologic response, and possibly increasing the risk of side effects at the same time. So the concept is solid. Vancomycin is an antibiotic that I'm going to talk about during the antibiotics lecture, of course, and I'm going to go through some kinetics examples. Vanco is one of the drugs that, one of the few drugs out there that we're still doing a lot of regular monitoring on, that we use quite frequently, because we really need to be hitting specific blood serum concentrations. And if we get too low, for example, if we're dosing somebody twice a day on vancomycin, and if our level, our trough level, meaning the lowest level we're getting on the Vanco, gets too low before we're giving that next dose, that can cause problems, because we really want that drug concentration to be at a certain point to maximize the bactericidal effects of vancomycin. And I'm going to talk about that a little bit later with the antibiotic lecture. So to kind of piggyback on some of that I just talked about, there's two concepts that are really critical for understanding how drugs work, how they're absorbed, how we dose things. These two are really I guess, building blocks of all pharmacology. So we have half-life and steady state. Half-life is often abbreviated T1/2. And the diagram right next to half-life here shows it pretty well. So what happens is you get a drug, it hits its Cmax. Half-life is the time it takes to lose 50% of that. It's pretty straightforward. So the question you get is, how long does it take for the drug to lose its efficacy? And that's a great question, because we don't necessarily know that. But usually you can look at it from a perspective of when is the drug fully out of the system. So after one half-life, you've lost 50%. After another half-life, you've lost another 25%, and then 12.5%, and then down from there. So the question is, how long does it take to really eliminate the drug fully from the system? And then alternatively, the drug's eliminating as you give it, so how long does it take to reach steady state? Well, what steady state is the rate of you consuming, your patient consuming the drug equals the rate that they're eliminating the drug. So here is a diagram where you can see basically how steady state works. So you see here an oral dose. So we're taking it, we're reaching our Cmax. It starts to get eliminated. Oh, we just took another dose. So then we're popping back up, and another dose, and another dose. And eventually this kind of evens out where your elimination is reaching the point of which you're administering the drug. And that's ideal. Now, you could reach a problem where you're giving too much of the drug and your curve is moving up too far, too high, and you're going to get side effects at that point. Or you could be reaching a point where you're getting too low and you aren't dosing it effectively enough, or the patient's eliminating it faster than you're giving it, and then you aren't reaching it. So steady state is really hitting it right in the middle, getting that rate in equaling the rate out. Usually the rule of thumb is we say that this process, either getting up to steady state or fully eliminating the drug, takes 5 half-lives. If you want to cheat, you can say 3. Why 3? Well, if you add 50, 25, and 12.5, you get pretty close to 100%, not quite there. With 87.5%, we usually consider that pretty good. So let's say you take one dose of a drug. If you wait 3 half-lives for it to eliminate, you can safely assume almost all of that's out of the system by then. After one half-life, you're only losing 50%. So at that point, you still have a fair amount of drug left in the system. After 5 half-lives, you've lost 95+%. So at that point, you're looking at fairly confident. You can be fairly confident that the drug is no longer really in play anymore. And the same thing applies to your steady state. So I know we're talking about half-lives being about elimination, but it's also about accumulation of the drug too. So the half-life is important because the drug has to eliminate it at a certain rate and you have to dose it again. So this is where dosing frequency is really determined in a lot of clinical trials for pharmacologic agents. Is they look at the half-life of the drug, they look at the kinetics, and they can usually look at the way they want to do the dosing, whether it's going to be once a day, twice a day, 3 times, 4 times, whatever it may be. That's going to affect that substantially. Now, that's not always the case. Sometimes you'll see a drug that's just once a day and you look at the half-life and it's like 5 hours. And like, well, how does that work? Well, it may have other actions that last longer or effects that are longer lasting than the actual product itself. Sometimes that gets a little bit confusing, but usually you can base the daily dose off the half-life. So if you see a drug that has a half-life of 24 hours, it's a pretty good bet that drug is going to be a once-a-day dose medication. Now, not all kinetics are nice and linear like that. So when you have something that has nonlinear kinetics, you have to be really careful. Now, there aren't a lot of drugs out there that do this, fortunately, and not a lot of drugs that we care about that do this. One of the drugs is called phenytoin. Phenytoin's abbreviated here, PHT. Phenytoin's an anti-epileptic drug, and it's notorious for having this exponential response. So when you give phenytoin, you get sort of a linear base increase as you're starting out, and then you hit this therapeutic window, and then as soon as you start to get up, all of a sudden you're getting exponential increases of phenytoin. So when you get to higher doses of phenytoin, you just have to know that if you give somebody, if you double their dose, you could almost see a 4 times response or a 6 times response, maybe in an elderly patient, of their serum blood concentration. So phenytoin is one of those drugs that we monitor via blood concentrations to make sure that they're in that therapeutic window, especially when we're changing therapy. The question is, why does it do this? Well, drugs have different ways of elimination. Phenytoin is really strongly protein bound too. So what happens with phenytoin is you can get free levels that get really highly increased once the binding sites on protein are saturated. So you have serum albumin that a lot of drugs bind to. So if you have phenytoin on board, your phenytoin is trying to bind to that protein, and then there's sort of an exchange going on between what's available bound to albumin and what's free within the bloodstream. And so that's a part of it, I believe. And then there can be some elimination things too that we're going to talk about a little bit later that might affect it as well. Okay, so that's about pharmacodynamics. Hopefully that makes sense. Again, if there's something that sounded confusing, feel free to email me and ask me any questions about that. Now, kinetics, what the body does to drugs, are going to come into play a lot throughout the semester or throughout the year as well. So these are some really key concepts. We're going to go through the 4 major parts of pharmacokinetics, which is ADME, absorption, distribution, metabolism, and excretion. Pharmacokinetics, essentially it's drug movement. Think about the drug moving throughout the body and the body doing things to it. All right, absorption. Absorption is really important from a patient convenience standpoint. It's important from a site delivery standpoint. It just depends on what we're trying to do. So of course, if we're treating treating a disease like asthma or COPD that's primarily pulmonary, we want that medication to get right to the lungs. So there's no point really in giving somebody oral medication if we can give an inhaled medication, because we know for sure that's getting to the pulmonary vasculature system. So I'm just showing you some examples here. There's a bunch of them. I mean, we can give things otically, ophthalmically. Tons of topical products that not only work locally, so we have plenty of topical creams and stuff that work for dermatologic conditions, but there's also topical products that are absorbed and will actually get into systemic circulation, like some steroid replacement like testosterone. There's also some other menopausal related treatments too that work that way. You have subcutaneous injection here, like this guy is doing with maybe an insulin pen with a really fine needle that's getting into the subcutaneous fat and then absorbs slowly into systemic circulation. Tablets, oral tablets, of course, and then also taking things under the tongue. Sometimes we dissolve things either buccally in the cheek or under the tongue, and that creates a faster path to the bloodstream as opposed to swallowing it and going through the GI tract. IV medications are of course going to get straight into the bloodstream, so we don't have to worry really about much metabolism or any absorption issues with that. Transdermal products like patches are really nice for long delayed releases. So sometimes you can do like a once weekly product that is designed so that the patch slowly releases it over time. Of course, you have IM shots here, like President Obama getting his flu shot. Things like suppositories too are used for rectal administration. So the list goes on and on and on. There's lots of ways we can do this. And pharmaceutical companies are always thinking about new ways to either enhance current technique, like maybe creating a new oral dosage form that has a different release mechanism when it's absorbed, or maybe a new type of inhaler that has a little bit of a different way that you use it. Just to improve patient compliance, improve convenience for people too is a big thing as well. All right, so when we're looking at systemic administration, these are common drug delivery mechanisms. So really, IV is going to be your hallmark here. And I've got a column in the middle called bioavailability. Bioavailability is how much of the drug's getting into systemic circulation. So an IV product, by definition, is going to have 100% bioavailability. You're giving it directly into the bloodstream. All of it should be getting in. And now, some of that might get metabolized fairly quickly, or it might have a short half-life or whatever, but at a certain point, as soon as that drug hits the system, it's all there. You aren't losing any of it. Whereas if you think about every other way, even if we have almost 100% absorption, you're still going to lose something. So every other system is going to have less than perfect every other system of administration, I should say, will have less than perfect bioavailability. So you can see subcutaneous and IM both have pretty good. Oral is highly, highly variable. Some drugs have very little bioavailability, but it doesn't matter. For example, well, if you think back to our other topic here, the pharmacodynamics talked about potency and things like that. Some drugs you may not need all that much to actually get absorbed. Or if the drug company is developing a medication and they know only 10% is bioavailable, well, they can dose that appropriately so that they know that, well, let's say we need 10 milligrams of the drug to get adequate serum concentrations to produce therapeutic effect. Well, let's give a 100 milligram dose. We know that 10 milligrams of that will get absorbed. The rest of it's going to get excreted out with the feces. So they'll design things specifically around that. Rectal has pretty decent absorption. Inhalation usually has pretty good absorption, and transdermal has good absorption as well. Now we're going to talk about why this is. Some of these go through more metabolism than the others. I'm going to talk about metabolism here in a couple slides. Some other things to point out: IV, most likely the fastest onset. Inhalation is quite fast too. You get direct access to the pulmonary vasculature, which sends you into the bloodstream very quickly. There's lots of different convenience things to think about. Most people really have no problem taking pills. Swallowing something is not difficult for many people to do, so it's an easy thing to add on to somebody's regimen. All the other things can be a little bit tricky. Inhalers require quite a bit of education to use correctly. I think people think inhalers are easy to use. Well, there's actually a lot to using an inhaler properly that I think a lot of people don't really understand. Transdermal patches and stuff can have problems with skin irritation. They can come off with excess sweating or water exposure. They can increase their delivery if they're exposed to heat. So there's lots of problems with that. Subcutaneous products may cause local irritation. There's lots of things to think about when you're giving different delivery mechanisms. Okay, so I talked about metabolism being a big effect. And really with metabolism, you're looking at a lot of these mechanisms, at least specifically with respect to talking about first pass metabolism with oral dosage. So when we're designing other delivery mechanisms, one of the nice benefits of pretty much anything besides oral doses is that they avoid first pass metabolism. So in this case here, we have a diagram showing first pass metabolism. Basically, you take your oral tablet, it gets broken down, your drug's in your gut, it absorbs through the GI wall. Now, the GI wall has a lot of enzymes and stuff in it. So as soon as your drug gets absorbed, there's a chance that some of it's going to get lost right away. So you're already losing a certain percentage here via GI wall metabolism. So that's part of first pass. Second part is when you get absorbed into the portal vein that takes you directly to the liver. Now, the liver is the ultimate graveyard for a lot of medications because the liver is our big metabolizing organ. It has all the enzymes in it that break down various things that the body takes in. It's not designed. It's kind of cool because the liver has all these enzymes that it produces that break down drugs, but they also break down a lot of environmental exposure to whatever things we're taking in that we don't want. So you have a lot of first pass metabolism here going on in the liver. The liver is going to chew up a various amount of drug too. And then finally, whatever comes out of the liver is what your bioavailability is. So depending on how significant your first pass metabolism is, you could lose a lot of drug before you even get into systemic circulation. So when we're looking at other dosage forms like inhalation or transdermal or sublingual or rectal, those avoid first pass metabolism. And by doing that, you can get higher blood concentrations, more drug into systemic circulation. All right. talk about distribution a little bit. V is a term I'm using here to describe volume of distribution. V is for volume. So what distribution really is you're giving a drug to a person, and it's how much of that drug, amount of drug you give in the body versus the blood concentration. Now, to figure this out on an actual realistic scale, you would have to give somebody a drug and then, I don't know, put this is going to sound really morbid, put the entire person in a blender and then figure out what the concentration is. Of course, we are never going to do that. So you take serum concentration and try and figure it out from that. But the problem is that drugs distribute all over the body. So depending on what type of chemical they are or what type of molecule they are, you can go in multiple different places. So some things to remember about drug distribution. Well, drugs distribute with their concentration gradient. They're going to go to places with less concentration, of course. Blood, total body water, extracellular spaces, lymphatic tissue, cerebrospinal fluids. These are all things involved in distribution. So you can see how just measuring blood concentration might not give you really that beneficial of a serum level. So you can look, well, okay, let me rephrase this. So let's say you're doing a clinical trial and you're measuring blood concentration of a drug that you know has to get into the central nervous system. Well, okay, that's fine, but you may not be actually getting into those cerebral spinal fluids that is maybe your site of action of the drug. So you're looking at blood concentrations that maybe correspond to therapeutic benefit, but as far as the total volume of distribution, you may not be actually measuring that. So hopefully that makes sense. I'm not trying to make this more complicated. I'm just trying to explain that drugs go all over the body, and a lot of times we just look at blood concentration, which is usually almost like a surrogate marker for where actually the final endpoint of the drug is going to be. So some other things, drugs may be bound to plasma or muscle proteins, so plasma proteins, specifically albumin. Other drugs, and this is a big one, dissolved in body fat. So drugs that are highly lipophilic molecules will distribute more into fatty tissues. And both of these processes, either distributing into the fatty tissues or just getting bound to protein, will usually delay distribution to the site of action in some situations. Now, other times, if you have a really lipophilic drugs can cross the blood-brain barrier really easily as opposed to drugs that are more hydrophilic. So that can actually be a beneficial thing about giving a drug, is that it may distribute into the central nervous system quickly, but at the same time, it may also leave the central nervous system quickly and distribute into the fatty tissues of the body. So there's multiple things at play here and a couple different things to consider. All right, so talking about protein binding again, example. So if you have a patient with a low serum albumin, likely going to have a higher free drug concentration. So somebody who's malnourished, cachectic, if you're giving them a drug that is reliant on serum albumin binding, you're going to have higher free concentrations. So that means you can likely need a lower dose overall. And also, your standard blood concentration monitoring may not be effective. Some drugs you may actually have to order a specific free level of that's checking not only that's not checking the protein binding, but checking actually how much free drug is available in circulation. An elderly patient with lower muscle mass, that can affect distribution, of course. Obese patients, patients with a lot of adipose tissue, are going to have a higher V for lipophilic drugs, but at the same token, if you give them a hydrophilic drug, you may actually overestimate their volume of distribution. So their volume of distribution may actually be fairly similar to a non-obese person for a non-lipophilic drug, but when you give a lipophilic drug, it's going to get much higher. Fluid accumulation, edema, ascites, pleural effusion, these can all cause different V for hydrophilic drugs too, so other things to consider as well. This slide, you're going to look at this and say, what the heck is this? It looks really complicated, and it is. It's supposed to look complicated. So the only point I'm putting up with this is that blood-brain barrier has a lot of different transport mechanisms, and we can give drugs that work with these transport mechanisms. So you can see like amino acids do this, insulin can transmit through here, albumin has some pathways. So there's multiple pathways you can get through here, and we can give drugs that work with those. Now the nice thing is that anything that's lipid soluble or lipophilic drugs can just pass right through. They don't need any transport mechanism. They don't need anything to get through. Water soluble agents have to pass through a tight junction, so it's going to limit their absorption a bit. It's going to take them a longer time to penetrate the blood-brain barrier than it would a lipid soluble agent that can just freely move through wherever it wants. All right, so we talked about absorption, talked a little bit about distribution. Now we're on to metabolism. Metabolism is really, really important, especially with pharmacologic agent selection. This is going to be something that comes up time and time again is metabolism. So a really critical concept here. But to give a little background, metabolism, just biochemical processing of drugs. And of course, other things get processed by metabolism too. But biotransformation is another word you may hear, because metabolizing is really just changing the drug into something that can get eliminated. So we give a drug. It's designed to stay in the body, cause a certain effect, but eventually the body's smart enough to figure out a way to modify that molecule and get it eliminated out via the kidneys or some other mechanism. Not all drugs are metabolized. Some may just be excreted unchanged. Some drugs may not undergo any metabolism. They may just eventually get to the kidneys and get renally eliminated. Metabolic journey of what a drug that a drug takes is what determines its duration of action. So we talked about half-lives and that steady state and that type of stuff. Well, a lot of that has to do directly with metabolism and elimination. Depending on how heavily metabolized your drug is, it may or may not have a longer duration of action. Also, there's a lot of metabolic byproducts that can be pharmacologically active. In fact, some drugs we give orally may not have any pharmacologic action, but are actually designed to be metabolized into something pharmacologically active via the liver. And so that's called a prodrug, and it's kind of a smart way to do it. And I'll show you an example, one of those here in a second. So when you think about metabolism, every tissue in the body has some ability to metabolize, but the liver is really our major player here. The GI tract has some good amount, lungs, skin, kidneys, brain all have some capabilities, but the liver is really the primary player here. We talked about first pass metabolism from the GI tract and intestinal metabolism too. I want to just mention enterohepatic recycling really quick. I'm going to talk about this when I talk about certain drugs because it's more important when we talk about specific drugs. But enterohepatic recycling is a way that the body basically just recycles molecules and other things. So if you have drugs that are undergoing enterohepatic recycling, what's happening is that metabolic byproducts are getting excreted in the bile. They're getting shot out back into the GI tract. So they've gone into systemic circulation. They floated around. They've gone through the liver. They've gotten broken down into metabolic byproduct, and they're getting eliminated in the bile. Now you have various microbes in your gut that can change those into something that may be able to get reabsorbed. So let's say you excrete a drug that's been altered by the liver. Well, some bacteria picks it up, changes it back into the original molecule it was, and then that sends it back into the body and gets reabsorbed that way. That's essentially the concept of enterohepatic recycling. So some drugs have extended durations of action because they undergo enterohepatic recycling. So with that in mind, because this process is dependent on GI flora, anything that's disrupting GI flora, like antibiotics, may disrupt this enterohepatic recycling system. It's not really a super well understood mechanism, or clinical effects really are a little bit ambiguous as to how that could come into play. Is it going to really decrease the effect of the drug? If you stop that process, it's possible, but we don't really know. There aren't really any great examples of that being seen clinically. So it's just something that's kind of interesting that we know happens, but we don't really know the full extent of the impact of it. And then I put spontaneous metabolism. There are a variety of things that float around in the bloodstream, like specifically esterases is one of the things I think about. Esterases are just kind of they're enzymes that dissolve, that can break down various products or alter products to make them get excreted. So maybe a drug doesn't have to go to the liver. So if you give something IV, maybe it runs into some esterases and that metabolizes it and breaks it down so that it gets shot out and eliminated that way. All right, so let's focus on the liver a little bit more. Hepatic enzymes, again, are a huge role in drug metabolism, and something that I'm going to talk about again and again are cytochrome P450 enzymes, aka CYP enzymes. So I put CYP XXX there. CYPs all have a 3-digit code next to them, and we're going to talk about those on the next slide. So oftentimes throughout the course, I'll refer to, oh, this drug is CYP3A4 metabolized, or this drug inhibits CYP3A4, or this is 2D6 or 2C9. And what I'm getting at whenever I'm talking about CYP enzymes is that anything that's highly CYP metabolized is going to be prone to drug interactions. So, and I'm going to highlight this a little bit more in a slide or two, but what you have is problems where where drugs are competing for different enzymes. Certain drugs affect different enzymes more, and I'm going to give some examples of those here in a moment. So what CYPs are, CYP enzymes metabolize via oxidation reduction reactions. So when you go through the liver, usually your phase 1 metabolism is going to be using the cytochrome P450 system of enzymes. And there's a whole bunch of them, probably, I don't know, 100, maybe more, who knows how many there are, but they all metabolize via oxidation reduction reactions. Now, sometimes that may be enough. They may undergo oxidation reduction, molecule, and then it gets excreted or eliminated that way. Other times they may go on to phase 2, which is getting conjugation or hydrolysis. And these are different types of hepatic enzymes that work in these situations. Most drugs are going to undergo multiple phases of metabolism. All right, so looking at common drug metabolism here, this pie chart, so if we look at the redox reactions in phase 1 here, so remember these are CYP enzymes for the most part. We have our CYP1A2, 2A6, 2C9, 2D6, 3A4. You can see that a lot of drugs are metabolized by a couple major enzymes. So if you remember like 3A4, 2D6, 2C9, you're covering more than half of your CYP metabolism there. So a good rule of thumb I like to think about is if you're ever looking up drug interactions and you're like, oh, this is metabolized by 2C9. Well, that should stand out as a red flag to you that that's going to be a possible cause of drug interactions, or it's going to be more prone to getting affected by drug interactions. Now we have our phase 2. There's a bunch of enzymes that affect glucuronidation. Now these are really not as prone to drug interactions. We don't really, they may very well be, but usually for the most part, we don't think of them that way. So there are some drugs that will interfere with this process, but for the most part, we're much more concerned about the CYP system. All right, to illustrate some of these, you guys are looking at this slide being like, oh, great, I have to know structures. You don't have to know any structures. I'm just showing you some examples here. So this is a drug, morphine. I think everybody probably knows what morphine is. It's an opioid painkiller. Codeine is also a common opioid painkiller, cough suppressant as well. So codeine is actually metabolized into morphine in the body. So if you take like a codeine cough syrup or something, you're actually taking morphine, because codeine is eventually metabolized into morphine and some other things. It just, if you were to take straight morphine, that's a much more, you're getting a lot more morphine, whereas if you took the same amount of codeine, your body can only metabolize codeine to morphine at like a 1-to-10 ratio or something like that. So I could get quite as much morphine out of it. But anyway, you can see here that, let's say you take a codeine, it gets undergoes CYP2D6 metabolism here, gets converted into morphine. Morphine will eventually get glucuronidated, if that's a verb that I can use and make up, and into these. So you can see they're adding, the body's adding these structures onto it. What this does is it makes the molecule extremely polar, and that allows the kidneys to filter it out easily. So you also get some other metabolism going on here too. So we see CYP3A4, CYP3A4 here, and these can get metabolized into other byproducts too. Now these byproducts can have specific action too. These may have some opioid action as well, along with the parent compound. So the body will eventually be working at getting rid of those as well. But you can see this process has multiple steps, so it takes some time. Sometimes you end up with circulating products and multiple steps, so that may make the product actually last longer in the body. So you're getting active metabolites that are having similar effects as a parent compound. It's taking the liver a couple passes potentially to get rid of all of that. And you also only have a finite amount of liver enzymes. It's not like you can infinitely metabolize things. So if you max out some of these pathways, you may get increased availability of the drug because it's not being able to be metabolized by the liver at that time. As this NAPQI. So you're ending up building up these hepatotoxic intermediates, and that's causing the problem there. So that's a kind of in a nutshell, looking at acetaminophen metabolism and how it, by using up these different hepatic processing metabolizing systems, that we can end up with a very relatively safe drug, very commonly used drug, going into something that can be possibly hepatotoxic and causing hepatic necrosis. All right, so I mentioned prodrugs. Prodrugs, again, are drugs that are taken, and we use them specifically because we know that they're going to be changed by the liver and into their active metabolites. So clopidogrel is the brand name Plavix. Plavix or clopidogrel is used as a platelet inhibition agent. It's used post-MI. It's used in a lot of different cardiac indications, stroke indications. Plavix undergoes intestinal absorption as its base molecule, clopidogrel. It gets metabolized into this oxoclopidogrel via 2C19 and some other ones, and then CYP2C19 also further goes on to metabolize this into its active metabolite. So actually, the original parent compound has to undergo two-step metabolism to get to that point where it's reaching its final destination as an active compound. So the thing to remember about prodrugs, not pharmacologically active and metabolized into a pharmacologically active compound. Okay, let's talk about some induction inhibition. This is really important. Pretty much anytime we're talking about drug-drug interactions, or if you ever hear about drug interactions, or think about somebody's like a pharmacist who's going to check your drug interactions on your profile or something like that. This is really what it's coming down to, the most part, is these CYP enzymes. So two big things, inducers and inhibitors. Inducers are compounds that are going to cause increased enzymatic activity. So these are less common than our inhibitors. Examples would be drugs like rifampin, carbamazepine, and phenytoin. Not all of these are not really commonly used. Inducers are fairly rare. We don't really have to worry about them too much, but every once in a while you find somebody on an inducer and you're like, oh, is this going to affect other things? And you really got to think carefully about it. Inhibitors cause decreased enzymatic activity. So there are a ton of examples of these. We're going to go through, I'm going to point these out as we go through our course together. But inhibitors are going to come back time and time again. A lot of drugs have some sort of inhibition property. There's some that are really, really hallmark inhibitors. Other ones are just kind of maybe have some mild inhibition. And so the thing to think about is if a drug is inducing enzymatic activity, you're going to end up with less concentration, less effective of your parent compound. So if your parent compound that you're thinking about is being metabolized by CYP3A4, and you give them carbamazepine, which inhibits CYP3A4, that's going to mean that you're going to have, I'm mixing up my terms here and probably confusing you guys. You give somebody carbamazepine, which is going to induce CYP3A4. That's going to cause increased metabolism of your parent compound and lower efficacy overall of that parent compound. Whereas inhibitors work the opposite way. You're removing your body, or you're inhibiting your body's natural processing and metabolizing of these compounds, so you're going to get increased availability of that compound. Sometimes we actually use this to our advantage, specifically with HIV therapy. We give drugs that we know inhibit the enzyme so that we get higher levels. It's called boosting, and we'll talk about that when we talk about HIV. Some drugs have shared metabolic pathways. So, for example, if you give two drugs that are both strongly CYP3A4 metabolized, they're going to compete with each other, meaning that they're both probably going to come out with a bit higher concentrations than they would if you gave either one of them alone. Usually, kind of a rule of thumb is if we know a drug is a strong CYP inducer, a strong CYP inhibitor, we try to avoid them, just because you never really know what a person's going to be needing to take, and it could limit your options down the road. If you want to give a certain drug, and you're like, well, they're on carbamazepine, that's a strong inducer, can we really give this? It may limit your options in certain situations. Sometimes, if we can, we like to just avoid these really strong inducers or inhibitors altogether, but that's not always the case, and there's often times where we have to give them, and we have to just work around that drug interaction potential. All right, some metabolic considerations to think about. These metabolism pathways, these CYP pathways that I was just talking about with drug interactions, have a lot of individual variants. There's been a lot of studies showing genetic polymorphism, specifically with certain ethnic groups. So some ethnic groups have really strong ultra metabolizers are what the term is used for, but they may have really strong expression of certain CYP enzymes. So maybe they have really high 3A4 activity, but they may have really low 2D6 activity or something like that. It's just an example I'm making up at the time, but get the point is that genetic individual variance is a huge component. So you may have entire populations that have problems metabolizing certain drugs. Now, this can cause two issues. So first of all, you could have increased possibility of side effects. You're going to get higher blood concentrations with certain medications. Another thing to think about is when we were talking about clopidogrel or Plavix being a prodrug, what implications does that have? So if you have a drug that requires some sort of CYP enzyme to make it active, and you have somebody who's a poor metabolizer, well, they aren't going to be able to metabolize that drug into enough of the active compound to possibly elicit a clinical response. So this is where the field of pharmacogenomics comes into play. Pharmacogenomics is something that's been talked about a lot, and it's been there's been some more and more applications of it coming out. What it is it's looking at somebody's specific genetic makeup, to see if they are more prone to being affected by a certain drug. And really the current clinical applications to pharmacogenomics have to do with liver metabolism. So for example, with Plavix or clopidogrel, there's actually a test that they can do to see how well somebody will respond to it. And if somebody's a poor responder, they'll consider an alternative to it that doesn't have that same metabolic pathway but works the same way as the drug. So there's multiple applications to pharmacogenomics. I think this is going to be a growing field. It's been a growing field for the last several years. It's going to continue to grow. It's going to be something we're going to be seeing a lot more of. We're going to be seeing maybe more individually tailored regimens to patients who have these genetic polymorphisms, but we're still, I think, a ways off of that. A lot of this is hindered substantially by the cost associated with it and insurance companies being unwilling to pick up the bill for something that they don't really know if it's clinically beneficial or not. So more in the future, but right now it's not a huge role. If you work in cardiology though, and you're prescribing a lot of Plavix, you'll probably, or clopidogrel, you're going to see this test done on people fairly often. Diet and environmental, grapefruit, cigarettes, industrial exposure I wrote. Grapefruit juice is kind of a notorious enzyme inhibitor. There's some other fruit juices that do this too, but grapefruit kind of takes a bad rap. For grapefruit juice to really have a huge effect, you're probably looking at drinking a lot of juice on a regular basis, like maybe a full glass of pure grapefruit juice on a daily basis having an effect. If you eat a half a grapefruit once in a while, that's not a big deal for the most part. Cigarette smoking actually has been shown to induce certain CYP enzymes. So remember, inducers increase enzymatic activity. So sometimes patients who are chronic smokers may have increased processing and metabolism of drugs, which is a little bit interesting. And industrial exposure of various things can cause different types of metabolic issues. To look at age, elderly people and neonates are slow metabolizers. Everything in the middle is a little faster. Adolescents and young adults, as far as age spectrum, are going to be the fastest metabolizers. Not surprising there. Gender, young men tend to metabolize the fastest. Why men metabolize faster than women, unsure. They think that there's some sort of an association maybe with liver enzymes and metabolism with higher levels of androgenic hormones, but unsure. Disease states, hepatic, cardiac, pulmonary, thyroid, inflammatory diseases can all have various effects on metabolic considerations, so always something to think about. Not really anything specific I want to talk about with that, but just something to keep in the back of your head. All right, moving on to excretion. The kidneys are major players here. They excrete drugs and metabolites via the urine. So remember, all of our processing and metabolism by the liver is designed to make the drug more polar. So we make that drug into a more polar molecule. In that case, it can get excreted by the kidneys much more easily. Whereas if it's just getting recycled by the kidneys, it may get reabsorbed. You may get a little bit of elimination, but if it's the same compound, it may just be getting reabsorbed by the kidneys and back into circulation. Whereas if the liver changes it enough, the kidneys can filter it out really easily. Other excretion, lungs excrete a little bit via exhale, skin via sweat, feces, unabsorbed orally ingested drugs. If you take a tablet, some of that is going to get excreted in the feces. Not all of it will get absorbed. And then the metabolites are getting excreted in bile. I mentioned enterohepatic recycling. Not all drugs undergo that. So some metabolites will just get excreted in the bile and eliminated that way. And again, more polar the molecule, the more likely it is to be, the less likely, it is to be reabsorbed by the kidney. I was reading that incorrectly. So again, making things more polar gets them out of circulation easier. Okay, so when we're looking at kidney function, there's a couple things that we use to calculate. GFR is kind of the standard term, glomerular filtration rate. It's a measure of kidney function, can be used to estimate drug clearance. Standard drug dosing assumes normal renal function. So if you're looking at whatever drug dosing information tool you're using, and it says dose 50 milligrams twice a day. Well, that's assuming the patient has normal renal function. So you always need to be taking renal function into consideration. Really, really important. I see a lot of mistakes made with this in my practice, where people just ignore renal function and assume it's normal or don't think about it. And that can lead to dosing errors and possibly inappropriate side effects. So really make sure you're assessing the kidney function of the patient. And if you're prescribing a new medication, check to see if it's renally absorbed or renally eliminated, especially if the patient's elderly or has a history of any type of kidney insufficiency, renal insufficiency. So two standard calculations here. We have Cockcroft-Gault. Cockcroft-Gault is used for drug dosing. This is one that pharmacists tend to use a lot. I don't know if a lot of other professionals use it. Most of the other professionals use the MDRD equation, and they are different. They do give you different values. But the big difference is when you're looking at things from a specific, where do we use this? Why do we have two equations? Well, with Cockcroft-Gault, they've done a lot of the calculation around drug dosing. So when we're looking at modifying a patient's drug regimen based on their kidney function, we're going to calculate it with Cockcroft-Gault because that's the way it's done. That's the way all the studies have looked at it. Whereas the MDRD equation is used for CKD staging. So if you're going to stage somebody clinically and diagnose them with CKD, that's the equation you want to use. And again, they do give you fairly similar results, but they are usually different enough where it can cause maybe some discrepancies. So Cockcroft-Gault looks at age, weight, serum creatinine. It multiplies by 0.85 for females. Females get a little bit less because of lower overall muscle mass compared to males. You can see the MDRD equation is similar stuff. You're looking at age, serum creatinine. It takes in consideration African American patients having larger muscle mass than other ethnic groups, so it gives you a little bit higher of result for those patients. The nice thing about the Cockcroft-Gault is that you can memorize this equation and do it off a calculator pretty easily, whereas this MDRD equation, it's got these weird variables with it and multiplying factors that are difficult to remember and difficult to just plug into like a standard calculator. So Cockcroft-Gault is a little bit more user-friendly. Now, some things I'll point out about this quickly. Cockcroft-Gault equation is heavily reliable on three major variables. Well, they all are, but if you have a patient who is really heavy, they're going to calculate higher. If you have a patient that's older, they're going to calculate lower, and that's designed on purpose. The idea is that a patient that's heavier is going to have higher muscle mass, a higher creatinine clearance that way, or higher level of maybe a higher muscle and higher creatinine production potentially. Patient with lower age or older age, is just going to have worsening kidney function as you get older. As you get older, your kidney function declines naturally. So by increasing the age, you're decreasing the overall creatinine clearance. Some places may have a policies on what we use for weight. So for example, at my hospital, I work at Abbott Northwestern, we do weight very specifically as far as our corrected. So we look at a patient's lean body mass, and then we use an equation to correct that lean body mass on top of that. So it's kind of a balance in between their actual weight and their lean body weight. And then we use that number there. Now, for serum creatinine, we'll use what we get off of a lab value. However, if a patient is over 65, we automatically round them up to 1. Because sometimes you can end up with, if somebody has if you have like a really older person who doesn't have a lot of muscle mass, they may have a really low serum creatinine, and that can artificially inflate their creatinine clearance. So we just round it up to 1, and it gives it maybe a little bit more stability as far as the equation. These equations are not infallible, but if you use your clinical judgment, you can usually figure out what to do. So one thing I have as a rule of thumb, whenever you're dosing something renally, if you don't have access, so let's say you're in a clinic, you don't have time to you aren't going to get a lab or creatinine on the patient, but you know their weight and their age, obviously you know their gender, hopefully. Plug in 1 for their serum creatinine and just see what it would be. So if you have like an 86-year-old woman, you're thinking about prescribing an antibiotic that's renally eliminated, double check that and just plug in a serum creatinine of 1 and see what her creatinine clearance would come out to be. Maybe surprising how low it would be. So you really want to take those things into consideration when you're dosing medications. And I'll go over this a lot more when I'm talking about drugs that are renally eliminated and how we do that, but just kind of as a background, this is important stuff. All right, my Lord of the Rings thing here. One does not simply use creatinine alone to measure renal function. This is an important thing. You can't just look at somebody's serum creatinine and say, oh, it's elevated, or oh, it's low, whatever. Sometimes you can say, well, if their serum creatinine's off the charts and they have like acute kidney injury, well, yeah, obviously. But if it's like within the range of normal, but maybe on a little lower end of normal or a little higher end of normal, it's not just a simple, yes, that means their kidney function's fine. So if you see an older person specifically, all these mistakes I see, 90% of them are in the older patient population. So if you see an elderly patient with a normal serum creatinine, make sure you're doing a calculation on them and seeing what they're actually going to calculate out to, because they do likely need to be dose adjusted. Just make sure you're considering that. If you have any questions, again, my email, it's at the first slide, petcha@bethel.edu. I'll see you guys end of August for my first lecture. We'll do a little bit more of an intro lecture. I'll talk about a couple things I want to touch base on quickly, and then we're going to go right into antibiotics. So thanks for listening, and if you have any questions or concerns, just again, please email me or let your instructor know, and they'll forward that on to me. Thanks.